Good evening, viewers and subscribers. This is Althea again. Today, I am here to present to you a disease that has many crises, and it is called sickle cell. In this presentation, I will explain the following items. 1. The hemoglobin molecule. 2. I'll do a comparison between a sickle cell and a normal RBC. I will also explain what anemia is. And 4, how one gets sickle cell. And finally, I'll give an overview of sickle cell disease. I believe if you watch the entire video, that my objective will be attained. And it is for you to have a better understanding of this condition. So grab your favorite snack, and I'll be right back. What is hemoglobin? Hemoglobin is the oxygen transporting part of red blood cells. Normal hemoglobin is made up of 2 alpha and 2 beta chains, as shown in the diagram on your screen. In addition, the heme molecule contains 4 iron units surrounded by a porphyrin ring, which forms a tetrahedral shape. This normal hemoglobin is called hemoglobin A. Now, during gestation and right up to about 6 months after birth, a baby's hemoglobin is hemoglobin F, and that is quite normal. The problem arises when the child is about 5 to 6 months, and this is what takes place. So before I go into the genetics of sickle cells, let me recap. So far I told you hemoglobin A is what is normally found in RBCs. Hemoglobin A has 2 beta and 2 alpha chains. In comparison, hemoglobin F is not normally found in individuals older than 6 months old. So, in a baby, by the age of 6 months, the baby's hemoglobin F will be converted over to hemoglobin A. So the hemoglobin S molecule has 2 alpha and 2 gamma chains. And that's the main difference between hemoglobin A and hemoglobin F. So like I said a few seconds ago, by 6 months of age, baby's hemoglobin F is usually replaced by A. But in children that has sickle cell disease, this is not so. There are several different types of hemoglobins. We just discussed hemoglobin A and hemoglobin F. In addition to those, we have hemoglobin E, we have hemoglobin C, there's hemoglobin S, and so on. So now let's turn our attention to sickle cell. Sickle cell is a mutated gene. It is a result of a gene mutation, specifically the substitution of glutamic acid for valine on position 6 of the beta globin of a chromosome. It is an autosomal recessive gene. The sickle cell gene appears in 2 types, dominant and recessive. Dominant is represented by big S, and recessive is represented by small s. Okay? Now let's focus on the diagram on the screen. The two individuals on the top of the diagram, they are carriers of the sickle cell gene. They are said to be heterozygous. The person in black, that person does not have sickle cell gene. So that person, let's say that person have a normal A gene. The two persons in the middle, they are also carriers and they are also heterozygous. The person at the end in full red, that person is carrying the two genes. So that person has sickle cell disease and that person is said to be homozygous. Okay, so now we're going to look at another chart. So this chart is similar to the one you just saw. So we have the two parents at the top, and they're carriers of the sickle cell trait. And down the bottom, it shows the children. The blue is normal, and the red is the sickle cell gene. So the chance of having a child with sickle cell disease is demonstrated below. There is a 50% chance that the children will have the trait. There's 25% that the children will be normal and 25% that they'll have sickle cell disease. That's pretty much what the chart is showing. In order to help you to understand how sickle cell is passed on, I am going to let you listen to an audio, and it is from Scooter DMU. It's titled Sickle Cell Patterns of Inheritance. So listen up, and I'll come back on in a few minutes.
For the purpose of explaining how genes can be inherited. So this open educational resource will help you explore how the genetic condition sickle cell anemia can be inherited. You'll see how the parents can be carriers of the sickle gene and pass this status to their offspring. You'll begin to understand some terminology and the idea of genetic phenotype and genotype, and how these are determined by the passing of genes from parents to offspring. Finally, by looking at the inheritance patterns, you'll start to be able to calculate the chances of the offspring in acquiring certain genetic traits. So here's just some terminology to get you started. When we talk about genetic phenotype, these are the visible properties of that genetic inheritance. So someone with the phenotype that results in sickle cell disease, the patients will have various clinical manifestations of that disease associated with mainly anemia and problems linked to that. So the genotype is different, and that's the genetic information behind the scenes. That's the terminology that we can use to express whether someone is healthy or has acquired a genetic trait. When we talk about someone being a carrier of a gene, this is someone who maybe doesn't have the chronic illness, but actually might have mild symptoms, but they can still pass on that gene to their children. This person is a carrier of that condition. We really are dealing with the hemoglobin molecule here, which is the molecule in red blood cells that carries out oxygen for us. And in healthy adults, the vast majority of that hemoglobin is hemoglobin A, abbreviated to HbA. I mean, that does stand for adult hemoglobin, but it represents the A molecule. And there are many, many variants of hemoglobins. And Wikipedia talks about this really well, so do go and look at that. So hemoglobin A is the healthy, common adult default form of molecule. Hemoglobin S, HbS, is found in people with sickle cell disease.
Please listen carefully. The speaker is going to explain two different scenarios. One in which the mother, or let's say one parent has sickle cell trait and the other parent is normal. And then she's going to present the other situation in which both parents are carrying the trait. And this is very important. And you will see after you listen to the presentation that when two parents are carrying the trait, the likelihood of the child to have sickle cell disease increases. Okay, so this is very important.
Please note that I circled the two diagrams she's referring to. There are 4 diagrams on the screen. However, you should be looking at the two that is labeled 3 and 4, and I circled them for you to pick them out easily. All right? So she's going to talk about number 4 first, which is scenario 1.
And not all the variants are associated with illness. So in the first scenario, we're going to consider the mother is a carrier for the sickle cell gene and the father has normal adult hemoglobin. So we might depict it like this. So in this scenario, the mother is a carrier of the sickle cell gene, and you can see her genotype illustrated there with the abbreviation A, in that she has one normal hemoglobin gene, and S, meaning she is carrying the sickle cell trait also. When we look at the father, he has normal adult hemoglobin, so his genotype is expressed as AA. So what are the possible outcomes should this couple have children? Well, one of the outcomes is that the baby inherits the S gene from the mother, and of course is only going to inherit a normal healthy A gene from the father. And a second outcome, when you consider that there are two healthy options from the father, we'll end up with an infant with the same genotype, so the same characteristic potentially as baby 1, inheriting the sickle cell gene from the mother and the hemoglobin A from the father. So what other combinations could we get? We then could see the inheritance of the healthy hemoglobin A gene from the mother combining with one of the healthy genes from the father. So this baby will be of the genotype AA and will be having normal healthy hemoglobin. And then the same can happen again. So the healthy hemoglobin A gene from the mother can combine with either of those genes from the father. So in summary, what we can have is a 50-50 chance of any infant being a carrier also of the sickle cell. And we describe this infant as having the sickle cell trait. So they will have the genotype AS, and they may well be absolutely healthy and show no symptoms, but they actually might also show mild signs of anemia. But there's also a 50-50 chance of a totally healthy infant. So in the second scenario, we're now considering both parents having sickle cell trait, so having the genotype AS. So the mother here is the carrier of sickle cell, so the genotype is AS, and the same this time goes for the father. So what are the 4 likely outcomes for any infants? Well, first of all, the healthy hemoglobin A gene could be inherited from either parent, so this could result with a child with normal genotype, so normal healthy hemoglobin AA characteristic. But we might also see the healthy gene from the mother combining with the sickle cell gene from the father, so giving a child with the same genotype as both parents being potentially a carrier of sickle cell. And again, we might see this combination, so the alternate genes this time from the mum and dad, but also resulting in that same carrier genotype, so presenting with the genotype of hemoglobin AS. But we've got a 4th outcome this time, so you imagine if the infant inherits both of those sickle cell genes from the mum and the dad, then their genotype is going to be SS, and this will actually encode and express as full-blown sickle cell disease, and the infant may well suffer from some of the anemias and clinical presentations resulting in sickle cell. So this time there's only a 1 in 4 chance of a healthy offspring with the genotype AA. There's a 50-50 chance of any offspring being a carrier of the sickle cell trait, and there's a 1 in 4 chance of the child having sickle cell anemia with the genotype SS. In this final scenario, we're going to consider something slightly different, where each parent has a different variant of the hemoglobin gene. So adult hemoglobin A, of course, is the most.
That was a very good explanation by Scooter DMU as to how the sickle cell gene is passed on from parents to offsprings. I hope that made it a little bit clearer for you, because I know it can get a little bit muddy trying to maneuver these technical terms and abstract ideas. But I think that was a good breakdown of the process. Okay. Now let's focus our attention on the difference between the normal RBC and a sickle cell. So normal red blood cells are biconcave in shape. They are smooth and flexible, and they also are made up mostly of hemoglobin A, which has a great affinity for oxygen. In comparison, sickle cells are crescent-shaped. They are sticky and rigid. And when oxygen levels are low, they tend to become rigid and sickle-shaped. Normal RBCs carries a lot more oxygen than sickle cells. Another disadvantage with sickle cell is that normal RBCs circulate freely in the body, while sickle cells adhere to each other and to the walls of the vessels and causes jams, or what is technically known as vasoocclusions. Another difference in the two cells is that RBCs lives about 120 days, but sickle cell, on the other hand, lives for only a short period of 20 days. Now, sickle cell disease is seen most commonly in blacks. In the United States, sickle cell anemia and sickle cell disease occurs at a prevalence of 1 in 400 to 1 in 600 African Americans. But at the very get-go, I want to clear up a myth. Blacks are not the only race that sickle cell disease affects. Sickle cell disease can be seen in Hispanics, Asians, and other individuals from the Mediterranean and southeastern area. So, with that, we are going to go into some more detail about this disease. Here are some signs and symptoms of sickle cell disease. First sign that probably will be seen in children at birth is a baby that is fussy, that cries, and with swollen joints, fingers. That condition where there's swellenness and pain in the joint is called dactylitis. Now, other symptoms includes developmental challenges in children. They are slow growing. Severe anemia, and we'll talk about anemia in more detail at a little later time. Difficulty breathing. Patient is prone to a lot of infections. There's chest pain, leg ulcers. Child is usually underweight, and that will lead up even into adulthood. There is delay in sexual maturation. There is pulmonary hypertension, avascular necrosis, especially in the long bones, such as the femur and humerus. There's central nervous system involvement, for example, strokes. There is splenic sequestration. All that is swollenness. Spleen gets very large and aplastic. Chronic hemolysis of RBCs. What else? Eye problem, the retina. Patient will suffer from jaundice. Sometimes you'll see the white in the eye very yellow. There's gastrointestinal issues, as well as genitourinary involvement, such as kidney problems. So those are just a few of the symptoms. Now we're going to move into the diagnosis of sickle cell disease. So let's take a short little break, and if you have not subscribed to the channel as yet, I'm inviting you to do so at this point. Thank you. Now let's talk about the diagnosis of sickle cell anemia, or sickle cell disease. In the United States, all infants are screened at birth for sickle cell. A blood test called Sickle Dex is performed, or sometimes a wet mount slide can be done. Another test that is used is the CBC. The slide is examined for sickle cells and other abnormalities that are seen in sickle cell disease, such as target cells, polychromatophilic RBCs, Howell-Jolly bodies, hemoglobin C crystals, and so on. Electrophoresis is a test that is performed that is very crucial in differentiating the type of hemoglobins in a person's blood, and therefore that test is used to confirm sickle cell anemia. Now, I am going to let you listen to a video by osmosis, and this video will give you a good overview of sickle cell disease. And so please listen carefully. There's a lot of medical jargons in it, medical language, so to speak. Try to follow along and try to get as much information as you can. Okay? And then I will return. When I return, I will discuss some of the treatment that is available for sickle cell disease. All right.
cell disease, also called sickle cell anemia or just sickle cell, is a genetic disease where red blood cells can take the shape of a crescent, or sickle, and that change allows them to more easily be destroyed, causing anemia, among other things. Sickle cell disease is caused by defective hemoglobin, which is the oxygen-carrying protein in red blood cells. Hemoglobin is actually made up of 4 peptide chains, each bound to a heme group. Different hemoglobins have different combinations of these chains. Hemoglobin A, or HbA, is made up of 2 alpha globin and 2 beta globin peptide chains. This is the primary hemoglobin affected in sickle cell. Specifically, the beta globin chains end up misshapen. This is because of a mutation in the beta globin gene, or HBB gene. Sickle cell is an autosomal recessive disease, so a mutation in both copies of the beta globin gene is needed to get the disease. If the person has just one copy of the mutation and one normal HBB gene, then they're a sickle cell carrier, also called sickle trait. Having sickle trait does not cause health problems unless the person is exposed to extreme conditions, like high altitude or dehydration, where some sickle cell disease-like symptoms can crop up. What it does do is decrease the severity of infection by Plasmodium falciparum malaria. So in parts of the world with a high malaria burden, like Africa and pockets of southern Asia, those with sickle trait actually have an evolutionary advantage. This phenomenon is called heterozygote advantage, and its unfortunate consequence is a high rate of sickle cell disease in people from these parts of the world. Almost always, the sickle cell mutation is a non-conservative missense mutation that happens in the 6th amino acid of beta globin being a valine instead of glutamic acid. A non-conservative substitution means that the new amino acid, or valine, which is hydrophobic, has different properties than the one it replaced, glutamic acid, which is hydrophilic. A hemoglobin tetramer with 2 alpha globin and 2 mutated beta globin proteins is called sickle hemoglobin, or HbS. HbS carries oxygen perfectly well, but when deoxygenated, HbS changes its shape, which allows it to aggregate with other HbS proteins and form long polymers that distort the red blood cell into a crescent shape, a process called sickling. Conditions favorable for sickling include acidosis, which decreases hemoglobin's affinity for oxygen, and small, low-flow vessels where red blood cells' hemoglobin molecules have plenty of time to dump lots of oxygen molecules. Repeated sickling of red blood cells damages their cell membranes and promotes premature destruction. Since this happens within the vasculature, it's called intravascular hemolysis. This destruction of red blood cells not only leads to anemia, which is a deficiency in red blood cells or loss of the normal levels of hemoglobin, but also means a lot of hemoglobin spilling out. Free hemoglobin in the plasma is bound by a molecule called haptoglobin and gets recycled, which is why a low haptoglobin level is a sign of intravascular hemolysis. Recycling of that heme group yields unconjugated bilirubin, which at high concentration can cause scleral icterus, jaundice, and bilirubin gallstones. To counteract the anemia of sickle cell disease, the bone marrow makes increased numbers of reticulocytes, which are immature red blood cells. This ends up causing new bone formation, and the medullary cavities of the skull can expand outward, which causes enlarged cheeks and a hair-on-end appearance on skull X-ray. Extramedullary hematopoiesis, which is red blood cell production outside of the bone marrow, can also happen, most often in the liver, which can cause hepatomegaly. In sickled form, red blood cells tend to get stuck in capillaries, called vaso-occlusion. Starting in infancy, they can clog up blood flow in the bones of the hands and the feet, causing dactylitis, or swelling and pain at the digits. Later, they get stuck in other bones, causing a sickle cell pain crisis, or avascular necrosis of the bone. Red blood cells can also clog up the spleen, which can lead to an infarct of the spleen as well as an enormous backup of blood in the spleen, called splenic sequestration, a life-threatening complication. Over time, splenic infarcts can lead to autosplenectomy, where the spleen scars down and fibrosis to basically nothing. Having an absent or non-functional spleen makes a person susceptible to encapsulated bacteria, like Streptococcus pneumoniae, Haemophilus influenzae, Neisseria meningitidis, and Salmonella species. Since encapsulated bacteria are normally opsonized and phagocytized by macrophages in the spleen. It also leaves a person with Howell-Jolly bodies, which are basophilic nuclear remnants in red blood cells, which can be seen on a peripheral blood smear. Sickled red blood cells can get stuck in the cerebral vasculature, causing vessel damage resulting in strokes. Extensive sickle cell damage to the brain vessels may result in moya-moya disease, which is named for the puff of smoke collateral vessels that bypass blocked arteries. They can also get stuck in the blood vessels of the lungs, leading to acute chest syndrome. This is particularly dangerous because it sets up a vicious cycle of congested, deoxygenated red blood cells preventing other red blood cells from getting oxygen. And this is made worse by the lung's natural tendency for hypoxic vasoconstriction, which is blood vessel constriction in areas of the lungs that are low in oxygen. In addition, clogging in the renal papillae can cause necrosis, which can manifest as hematuria and proteinuria, blood and protein spilling out into the urine. And in men, clogging of the vasculature of the penis can cause priapism, a painful and prolonged erection. Given all of these symptoms, it's important to diagnose sickle cell as early as possible, so it's included in the newborn blood spot screen in some countries. It can also be identified with a blood smear looking for sickled cells or by identifying HBS using protein electrophoresis. The factors that cause red blood cells to sickle, which are hypoxia, dehydration, and/or acidosis, can be improved with oxygen and fluids, which are mainstays of treatment. In addition, opioids are usually used to manage pain, and antibiotics are used to treat any underlying bacterial infections, causing acute chest syndrome. Occasionally, blood transfusions are also used, but the risk of multiple transfusions include iron overload and the risk of developing new antibodies against future blood transfusions. Finally, children with sickle cell typically get prophylaxis with penicillin and an additional polysaccharide vaccine against Streptococcus pneumoniae to help prevent sepsis and meningitis with encapsulated bacteria. Another preventative medicine is hydroxyurea, which works by increasing the amount of gamma globin, which results in more fetal hemoglobin, or HbF. Fetal hemoglobin is made up of 2 alpha and 2 gamma globin chains, so it does not include the mutated beta globins. Since it cannot polymerize, it gets in the way of HbS polymers being made and prevents sickling. HbF is the primary hemoglobin at birth, which explains why sickle cell symptoms don't happen until a few months of life, when adult hemoglobin starts to predominate, which contains the mutated beta globin. More rarely, bone marrow transplants have been used in some patients, and given that sickle cell involves a single point mutation, gene therapy is another option being researched. Alright, as a quick recap, sickle cell disease is an autosomal recessive genetic disease where the beta globin subunit of hemoglobin is misshapen, which causes red blood cells to sickle when deoxygenated, and this leads to their premature destruction as well as vaso-occlusion. Furthermore, multi-organ damage is the end result from ongoing sickling and hypoxic damage to the body's important organs, resulting in a shortened lifespan.
So in that overview, you learned that there are several medications, among other things, that are available for sickle cell disease. That was a very well put together overview of the entire condition. And I think that covers most of what I would like you to know about sickle cell disease. So then, let's talk about what's the outlook for sickle cell disease. Well, there are still clinical trials and other research that are being done on this disease. One of the ways we can contribute is to take part in the clinical trials when we have the opportunity to, because that's how new innovations will come about that will help us to deal with this condition. The only cure currently for sickle cell disease is stem cell transplant. And stem cell transplant involves a lot. It's not a very easy procedure. The patient goes through a lot. I'm going to put it nicely. that way. And it has to be done during the early years. That means adults are not candidates for stem cell transplantation. So with that, I'm going to go into the next step, which is summarizing the entire presentation. It's a little long, and I'm trying to keep it, from going too long, because a lot of individuals don't like to listen to long videos, and it's already a little past the 30-minute mark. So I am going to summarize what we have discussed here today shortly. So in summary of hemoglobin S disease, we discussed the hemoglobin molecule. We talked about hemoglobin A. We discussed that it was the normal hemoglobin that is in the red blood cell after the age of 6 months, and that hemoglobin contains alpha and beta chains. Then we talked about the hemoglobin S, that it's a mutated hemoglobin, and we talked about fetal hemoglobin, which is termed hemoglobin F, and that hemoglobin contains 2 alpha and 2 gamma chains. We talked about the shape of a normal RBC and compared it with sickle cell. We talked a little bit about anemia. Anemia is when your iron level is low, and it is seen in several diseases. Those diseases are called hemoglobinopathies. Examples are sickle cell, hemoglobin C, and thalassemia. We also discussed the inheritance of the sickle cell gene, and we talked about trait status, that parents who are carrying the trait, even if they themselves do not demonstrate the disease, that they can pass it down to their children, and that's how the disease is transmitted. We also mentioned that sickle cell does not carry oxygen as well as the normal RBC, and we spoke of some of the manifestations of sickle cell. We talked about the hemolysis, the destruction of the spleen. We also talked about the transfusions, medications, diagnosis, treatment. What else? Yes. So with all that, ladies and gentlemen, I think at this point you should have a better understanding of this disease. You should be able to explain what sickle cell disease is in your own term. Explain it to, anyone that asks you what sickle cell is. And you also, which I would appreciate if you would point them towards this video. Share this video with them and say, listen to that video for further clarification. So, with this, I am going to close the video out. Please like and subscribe to the channel. Please hit the notification bell and select the all option so you will be notified of videos as they are posted. Now in the next video, I am going to talk about the thyroid glands, and I'm going to probably focus on hypothyroidism, and specifically Hashimoto's hypothyroidism. I think that's something that a lot of people are affected by, and so I think it should be on our top list. All right? So again, thank you for watching the video. You may have to break it down into two parts to watch it if it's too long. But if I did not cover all the things that I covered in this video, I wouldn't think that I did a good job in explaining it. All right? Thank you. This presentation was brought to you by ACES Merch. Imagine it, we can make it. So viewers and subscribers, for all your custom needs, please contact ACES Merch 813-850-2607 or hit us up at acesmerch@gmail.com.